At Wellcome, our vision for mental health is a world where no one is held back by mental health problems. You may have seen that we recently announced that we're going to be focusing on 3 health challenges for the next 30 years, one of which is going to be mental health, so we're very for the long term. And over the next 30 years, we want to help find the next generations of treatments and approaches to help or prevent mental ill health. So when it comes to workplace mental health, we're looking to collaborate with businesses and researchers to really understand what sorts of approaches could support employees' mental health and really kind of dig deep into the evidence around those. So to start around why workplace mental health in particular, at Wellcome, we're interested in mental health in lots of different contexts, but the workplace has been a particular focus since we started work in January of last year. So the predominant reason is that a lot of people spend a lot of time in a workplace. So if we can understand what works in this context, then we have the opportunity to really reach and help a huge number of people. And then in relation to businesses have the resources to try different approaches, and we already know that they're doing so. The kind of global wellness market is set to tip over about 60 billion next year. So huge amounts of money are already being spent by employers trying to support their employees. They also have a tendency to kind of join membership bodies like the World Economic Forum. So when it comes to reaching businesses to have this conversation about why it's so important to evidence different approaches to workplace mental health, they're quite easy and effective for us to reach. And also over the last year, it feels as though this conversation around workplace mental health has just become more and more important. And we can see it kind of rising up the agenda of kind of these large businesses. So it feels like a really opportune moment for us to be dealing with this. So in April last year, we asked researchers to examine existing evidence behind just one approach to workplace mental health with a particular focus on younger workers. And you're going to hear from 4 of the 10 fantastic researchers that we funded later on in this conversation. And while they're going to talk about kind of their experiences being part of the commission and what they found, I thought it might be helpful for me to say that there were kind of 3 overarching findings across 10 of the research groups. So one is that context is really important when it comes to approaches to workplace mental health. The second is that the existing evidence base is incredibly patchy, and that there's so much work to be done here to really kind of shore this up. And thirdly, businesses don't tend to make available any information that they have around how effective a particular approach has been. So it can be very hard to understand exactly the impact that's being had with the existing approaches. And that's something that we're really hoping to work with businesses on in the future. I also wanted to talk about how we share our work, because obviously we're funding the research, but we really have put lots of effort into making sure that this research gets into the hands of people that can make different decisions about the sorts of approaches and the evidence around them. So when our report came out, we did huge amounts of tweeting, we appeared on podcasts, we wrote blogs, we were on the front page of the World Economic Forum. Like, we know that we're getting this research into the hands of people that can make the different decisions. And so we'll be looking to do that with this next cohort of research too, and really continuing this conversation that we've started. And then the last thing I want to cover is just, I looked through some of the questions that were submitted ahead of this webinar, and I'm going to try and cover some of them, particularly around the kind of differences between the 2 commissions, because there are some things that are different this time around. So the first thing is that we're doubling the size of the commission. So we funded 10 research groups last year. We're looking to fund 20 research teams this time around. And we're looking for them to include those with lived experience in a way that we didn't before. And we have Kate, Grace and Naharika joining us as part of this webinar, who have fantastic expertise. So get your questions ready for them. The third thing is that the previous commission tried to focus on anxiety and depression and younger people. But as mental health becomes a bigger part of what Wellcome's doing, and we're going to be looking at age ranges beyond younger people and also conditions beyond anxiety and depression, we're lifting both of those focuses for this time around. And the fourth thing is that we're especially interested in research that's focused on workers in low and middle income countries. And of the 20 that we're funding, we're looking to fund at least 5 of those where the lead is based in a low middle income country. And we're also particularly interested in those who might be underrepresented or experiencing inequalities or discrimination in the workplace. The one thing that is consistent between the previous commission and this commission is that we're really keen to receive applications from any global location, any sector, or any career stage. So I'm going to stop there, Andre. I hope that has been a whistle-stop helpful review of what we're looking for, and I'm going to pass over to our fantastic researchers to talk about their experience with us.
That's great, Beck. Thanks very much. And you kept to time, which is wonderful. So setting a great example there for everybody else who's speaking today in the webinar. Great. So I am just going to now introduce you to the 4 researchers who carried out research projects for Wellcome last year and are going to be presenting their work here today. We're going to have 4 5-minute long presentations, and each of the researchers is going to tell us what workplace mental health approach they looked at with their research, how they conducted their research, what they found, obviously, and the key gaps and limitations in the evidence, and also some of the implications that follow on from their work. So we're going to have a talk from Ishtar Govia on mindfulness. We're going to have one from Will Phillips on financial well-being, from Julia Corrie on group psychological first aid, and from Ivan Robertson on employee autonomy. So some really interesting and diverse topics. And these talks are going to be followed by a 10-minute panel discussion. So if you've got any questions for our speakers, we keep saying this, but we really want to see your questions. So please do post them in the chat, or tweet them, or do something with your questions. Get them out there. And we will answer as many of those as we can as we go through. So Ishtar is our first speaker. Over to you, Ishtar. Do you want to share your screen and start your talk?
Hello, everyone, and thanks again for joining us. And thank you to Wellcome Trust for this opportunity to share our work. My name is Ishtar Govia, and I am happy to be here representing today a team of brilliant researchers and advocates, including Ms. Janelle Robinson, Ms. Rochelle Moore, Ms. Tiffany Palmer, and Ms. Marissa Stubbs. And we are representing the Jamaica Mental Health Advocacy Network, as well as the Caribbean Institute for Health Research. Our research focused on hospitality and tourism in low and middle income countries. We wanted to focus on a workplace sector that was very relevant to where young people are. Many of the countries in our region, we're from the Caribbean, many of the countries in our region are part of this hospitality and tourism sector. As you may be well aware, they're island economies, and these island economies thrive on tourism. 50% of the workers in the hospitality and tourism industry are actually under 25 years of age, and that's not just in the Caribbean region, it's globally. And in terms of Jamaica specifically, 31% of Jamaicans work in tourism. This industry clearly has specific risk factors for poor mental health outcomes, including things that we are often not speaking about in terms of vulnerability to abuse and harassment. So we wanted to focus on an intervention technique that is low cost, because we didn't want it to be exclusive to only persons who had resources, that was simple and adaptable and for which there is low stigma. And so we focused on mindfulness-based interventions. Mindfulness-based interventions, as many of you are aware, are based largely on mindfulness-based stress reduction and includes a number of practices as is illustrated here. For our research, we spoke informally first to persons from the sector, including managers and young workers, and we conducted an empirical literature review described on this slide below here. What we found is that there is no evidence that exclusively focuses on 18 to 24-year-olds, which was the age group of focus for this particular commission. And there was definitely none that focused on this age group in respect to the hospitality and tourism industry in low and middle income country contexts. However, what we did see across the multiple meta-analyses and reviews of reviews that we were able to look at, and then in the gray literature, having identified nine studies that focus, 9 randomized controlled trials that focus specifically on low and middle income countries, we found that mindfulness-based interventions were effective in reducing both anxiety and depression, and that this effectiveness cut across sector, organizational structures, duration of intervention, modality of intervention, type of control group, and age of participants. In addition to the randomized controlled trials, which focused exclusively on low and middle income countries, for which there was much less evidence, we also found that there were specific contextual factors that needed to be paid attention to, including the reality that these mindfulness-based interventions tend to be more effective for persons with a higher educational background, more years of education exposure. This has particular implications for low and middle income countries because persons who are working in this sector, as well as in many others in the informal sector, the informal economy, informal workplaces, are from an age group and from a contextual circumstance where education is not necessarily accessible to all or attained by all. And so this has important implications. So our consultees also identified barriers and facilitators and identified some key recommendations, including things like linking across different data sets that are available and recalling that mindfulness is not a one-size intervention that is meant to fit all. And I'll stop here for today.
Wonderful. Thank you, Ishtar. And apologies for not introducing you. That was terribly rude of me. I got so excited by the questions that I forgot to say who you were and where you were from. So thank you for filling that in. But yeah, Ishtar's joining us from Jamaica, where she's a senior lecturer in epidemiology at the Caribbean Institute for Health Research, and also director of the Jamaican Mental Health Advocacy Network. So yeah, thanks for that really great talk. And I've got loads of questions myself from what you've said, so I'm sure other people will as well. We've started to have some questions being posted in the chat, so thank you very much for people that are doing that. Feel free to post questions generally about the call for funding that's going to be discussed later, and also specific questions for our speakers here today. So our next speaker is Will Phillips, who's going to talk about financial well-being. Are you there, Will? Do you want to share?
I'm here. Hello. Sorry.
That's all right.
I'll share my screen.
And I will introduce you. So yeah, Will Phillips is an analyst at RAND Europe, working on health and well-being research, and his primary focus is research related to mental health and workplace well-being. And he's got a talk here, as you can see, on workplace financial well-being interventions. Great, over to you, Will.
Brilliant, thank you. So yeah, hi everyone. Thanks to Wellcome for giving us the opportunity to come present. So to kick it off, our research objective, as you can see on the screen, was to look at the impact of workplace financial well-being interventions on the mental health of young people. So why did we do this? Are a number of reasons, but mainly poor financial well-being is associated with mental health. That's an established link, and it's quite prominent for young people, particularly. Young people are saving less than they previous generations. It's harder to achieve afford a house now. And there's just generally a call for more investment in interventions to help young people with their financial well-being. Not to mention that the situation has just generally become worse because of COVID, growing inequalities in savings and employment, etc. So it is a prominent issue and one we wanted to look at more closely. So what did we do? So we split our research into two strands, a qualitative strand and a more quantitative strand. So for the qualitative work, we did a rapid evidence assessment of the academic literature linking workplace financial wellbeing interventions and mental health. And then we also did wider targeted reviews and searches looking at websites and policy documents, and also literature that was not specifically on young people or in the workplace, just to find relative findings. And then for the quantitative approach, we did a statistical regression analysis of a large workplace wellbeing survey. We work with a health insurance company called Vitality, who run a survey every year, which gives us access to very rich data on workplace wellbeing among participating companies' employees. So this survey has detail on all sorts of things: demographics, mental health, and whether people participated in workplace financial wellbeing interventions. So what did we find? From the literature, we found that there is evidence that these interventions can reduce financial worries, improve mental health, and also improve other aspects such as personal relationships. Some of the example content of these interventions you can see on the slide there, including financial workshops and other things like that. They were also found to be particularly useful for certain groups, including younger people, 18 to 24-year-olds, as well as people from ethnic minority backgrounds, women, and also people undergoing significant life changes. Worth noting a couple of limitations of the literature, though. The literature in this area is very, very limited. Of the 3 studies that we actually included in our final analysis, 2 were not with young workers specifically, and 1 was not in an employment setting. So there really wasn't one piece of literature that really hit the brief that we were looking for. Then moving on to the survey analysis, we found, again, evidence that participation is associated with improved mental health. And this was particularly the case for 18 to 24-year-olds, men, those on low incomes, those with lower levels of education, ethnic minorities, and people who believe there's discrimination in their workplace. Again, some key limitations to note. Unfortunately, because of the cross-sectional aspect of the analysis, we can only note that there's a significant association, not necessarily that there's causation from participation to improve mental health. It's also worth noting that the variable we use to denote participation in the interventions is just a binary variable, so we have no detail on number of sessions participated in or duration, etc. So it's a rather crude variable. Some other interesting survey findings. According to the employers that participated in the survey, 64% of young people do have access to interventions. However, when we ask the employees, only 12% of young people say they have access, which means that less than one in 5 young workers are actually aware that they have these interventions on offer. So awareness is very low. Similarly, of those that have access and know they have access, only 10% of them actually use them. So take up of the interventions on offer is also very low. That brings me to kind of our main policy recommendations. So the first thing is, on the whole, it seems that there is evidence to suggest that workplace financial wellbeing interventions are a promising approach for addressing mental health in young people. The interventions should be personalized and culturally appropriate. This is important because we saw that there were certain subgroups who were particularly at risk of poor financial wellbeing and who could benefit more greatly from them, such as people on low incomes, etc., as presented in the other slide. It's also important to make the content of the interventions appropriate for young workers. A lot of financial wellbeing interventions are very suited to older workers, looking at things like pensions advice for people approaching retirement. They could be suited to younger workers more. And then finally, as we just saw from those stats on awareness and take-up, it's important that companies really advertise and increase employee awareness of the interventions they have. Less than 1 in 5 young people know about them, and less than 10% of them actually use them. So it's important to really advertise and bolster them. And that's it. Thank you very much.
Thanks, Will, and thanks for keeping to time. That's grand. So yeah, post any questions you have for Will in the chat, please, and we will address those in about 10 minutes time when we start talking about all of these presentations. Our next speaker is Julia Corrie, who's going to talk about group psychological first aid for us. Julia, feel free to share your screen now. Brilliant. Julia is a researcher, a global health researcher at Trinity College Dublin, specialising in mental health, as well as reproductive, maternal and child health. Over to you, Julia.
Thanks. So our team looked at group psychological first aid for humanitarian workers and volunteers. And we focus on humanitarian workers and volunteers because they often live and work in difficult circumstances, and they're frequently exposed to traumatic events. They're twice as likely to experience depression and 4 times more likely to experience PTSD than the general population. So psychological first aid is a low cost and simple intervention that aims to prevent acute distress reactions from turning into long-term distress by instilling feelings of calmness, safety, connectedness, and hope. And the 3 main principles are to look for safety and for who needs help, to listen to the person who's in distress, to link to further support. And group psychological first aid is provided in the group format to individuals who have collectively experienced an acute or ongoing stressor, such as a natural disaster, a political conflict, or a disease outbreak, for example. It's led by at least 2 facilitators, and it takes place in small groups that are composed based on demographics, social and cultural norms, and stress reactions. And so our research asked the question, what works for whom, in what contexts, and why for group psychological first aid for humanitarian workers and volunteers ages 14 to 24. So to answer our question, our team conducted a rapid realist review, which involved developing preliminary theories as to how group PFA may work, and then conducting a systematic search of the literature. And we refined our theories based on the 15 included sources and input from experts. And so for our findings, we found that there are really not any studies that assess the effectiveness of group PFA. The literature is very scarce. However, it does suggest that it may be a practical and very scalable approach to providing support to humanitarian workers and volunteers, because it doesn't need to be provided by a mental health professional, and the group format reaches many people at the same time. It can help to promote positive coping strategies, psychosocial support, and group cohesion, and these can all have a protective effect and help prevent anxiety and depression. And it's important to note that group PFA is not a one-size-fits-all solution. The design and implementation is highly context-specific. For example, when composing groups, it's important to consider the social, gender, or age hierarchies that could impact power dynamics between both participants and facilitators. And there was no literature available that was looking at the use of group PFA with youth. So inferences drawn from other youth psychosocial interventions do suggest that the group format could be beneficial, but there's absolutely a need for more research on this area. And so using the available evidence, we developed a number of recommendations for the use of group PFA in humanitarian contexts. Whenever possible, it should be provided in at least 2 to 3 sessions to help build group cohesion. And icebreakers or group bonding sessions may be helpful for groups that don't already know each other. And in more chronic cases where the trauma is ongoing, for example, in the Ebola epidemic, more regular support can be beneficial. And organizations can also encourage ongoing communication among the members to increase social support. And this can be done through informal meetups or even creating a WhatsApp group for participants to keep in touch after the sessions. And it's important that group PFA is linked into wider support systems whenever possible. For example, through referring to resources that can help meet basic needs and provide further psychosocial support. And of course, not all contexts have these resources. So whenever broader support is not available, informal support is especially important. And that can be one-on-ones with facilitators after the session, or those WhatsApp groups or informal meetups. And group facilitators must have strong training and be able to provide empathy, manage the group dynamics, and create a safe and inclusive environment. The gender, the position, and the age of facilitators will differ depending on the context. And it's also recommended that it's led by at least 2 facilitators so that one can kind of lead the group discussions, and then one is available to take participants aside who are having more adverse reactions, and they can receive one-on-one support and be linked to further services. And in regards to group composition, it's very context specific, and considerations should be made based on the demographics, the level of exposure to the trauma, and the past experiences that individual has gone through. And youth are not a homogenous group. Sometimes they could be separated by 14 to 17-year-olds and 18 to 24-year-olds, but in other contexts, things such as marital status or different education levels can also impact the power dynamics. And at the individual level, people will have different needs depending on the situation. So it's really important that clear expectations for what group PFA can and cannot provide are established right at the onset. For example, if resources are limited for basic needs, that should be made clear upfront so that members are protected from further disappointment or distress. And then lastly, because youth are so impressionable within group context, it's especially important to identify those who are not benefiting from the group, or those who may be in acute distress, and take them aside to link them to group support, and that who's having that stress reaction, and then ensure that the rest of the group is able to receive the support needed without excess distress or stigma.
Great, thank you, Julia. Sorry, I'm cutting you off. Do you want to say your last bit?
Oh, that was all.
That was all. Okay, thank you very much. That's great. Really interesting work. So Ivan Robertson is our final presenter. He's going to be talking about employee autonomy. Do feel free to start sharing your slides, Ivan. Ivan is founding director of Robertson Cooper, who work to help organizations improve the mental health and well-being of their employees. And he's also Emeritus Professor of Work and Organizational Psychology at the University of Manchester. Over to you, Ivan.
Thank you. Can I just check that my slides are being shared?
Yeah, they look beautiful. Thank you.
Good. Okay, thank you. Hello, everybody. Let me just begin with a quick word about Robertson Cooper, because I think it's interesting in the sense that we're a commercial organization rather than a research institute or a university. We did spin out from the University of Manchester, founded by two professors, myself and Carrie Cooper. And what we do is provide an evidence-based service to organizations to help them with the mental health and well-being of their employees. We were founded 20 years ago, and over the period since then, we've developed a whole range of different interventions to introduce in organizations. And we built a very extensive measurement platform where we collect data on the drivers of mental health and the consequences of various kinds of organizational issues for people's mental health and well-being. And I'll come back to that a bit later. What we actually looked at was employee autonomy. The reason for that was first because we know that healthy jobs, psychologically healthy jobs, are really important for people's mental health and well-being. More than that, over decades of research in the literature, we also know the really core things that make a difference to people's mental health at work, in the workplace. And that's the demands, support that they get, and control or autonomy that they have over how they go about their work. And that was where we focused on control and autonomy, mainly because we felt it's the kind of discretionary thing that employers can, if they have the will, do something about, through the kinds of things on the right-hand side of that slide: more consultation, opportunities for people to utilize their skills, participation in decision-making, and so on. So that was our focus. What we actually did, whoops, I've skipped 2 slides there. Pretty much the same as others have done in terms of a search of the literature. The published literature, the grey literature, we made contact with colleagues, we sent messages out, we searched websites and so on. trying to find anything that would help us understand the relationship between job autonomy, anxiety, and depression. Like some of the other researchers, really, it was a very thin database that we actually came up with that was useful. It looks like we found a lot there with 277 included. Only 7 of the studies that we found actually looked at under 25s and had data on anxiety, autonomy, and depression as well. In addition to that, we tapped into the database that we have at Robertson Cooper with over 150,000 cases in that. And we cut that data looking at specifically under 25s, comparing under 25s with older individuals, and also looking at particular drivers and consequences for under 25s. And some of the findings that came out are listed on the slide there. Finally, we pulled together the findings that we had and made some recommendations. I mean, obviously, there's a jump from the evidence there to the actual recommendations. You have to make the links and put the recommendations together. But that was one of the requirements from Wellcome, and we were very happy to do it. Before concluding, I might just say a word about actually working with Wellcome over this period. It was a pretty good experience. This is from somebody who's done a lot of research over the years, worked with a lot of research institutions who sometimes expect researchers to do exactly what they say they will, but they don't do exactly what they say they will exactly on schedule. We found Wellcome were really good from the schedule point of view. We fed things into them for feedback. We got feedback very promptly, which was very helpful. And in general, I think very much improved the final quality of the work that we produced. So that's it from me. Thank you.
Thanks, Ivan. That's great. Do feel free to stop sharing your screen. I can see why you guys at Wellcome have asked Ivan to come along and talk. He's saying lovely things about you. I'm sure they're all true as well.
Unprompted.
Yeah, exactly. Thank you very much. So we now have just a few minutes to answer some questions that have been posed to you guys. And there are questions, actually specific questions for all of you in the chat that people have been asking. I don't think we're going to have time to tackle any of those specific ones, but do feel free to have a look in the chat and see if you can respond to some of those. I wanted to ask some general questions, I think, for all of you. So feel free to kind of jump in and answer these. I suppose the first one is that a lot of your work has found gaps in the evidence and limitations in the evidence. And I wanted to ask if you knew that that was going to be the case before you started doing these reviews, and if you adapted your methodology in any way to kind of account for that, to account for the fact that there were big gaps or big limitations. Who would like to come in on that?
Yeah, I'm happy to comment on that.
Sure.
Yeah, the specific answer to your question, Andre, is yes. We did expect that before we started the work. And to the extent that we could, we adapted the methodology. And I think the adaptations really were about casting the net as wide as possible rather than just looking at the published literature in the published databases, making sure that we made contacts well outside that. And then the second part was, which was why we put the proposal in the first place, we felt that we had an extensive set of data that we hold, that we have permission to anonymize and use for research purposes, and that we knew there would be plenty of data on under 25s in that. So that was a key part of why we did what we did. And it was done out of recognition of the fact that we wouldn't find much in the published literature.
That's interesting, isn't it? I guess workplace mental health evidence isn't always published in a conventional, academic journal.
Yeah.
So you kind of have to do a different sort of review. Does anybody else want to come in on that in terms of how they did that, how you found stuff? Yeah, Julia?
Yeah, I can add a little bit to that. So kind of similar to what Ivan was saying is we looked beyond just the published literature, and a lot of our sources were actually gray literature, and newspaper articles or things like that, more informal sources. And the other key thing that I think was really helpful for us was we had some experts who had actually worked in the humanitarian context and provided psychological first aid, and we got to speak with them and present our theories and kind of see if they thought that this matched up with their experiences. Now, unfortunately, we didn't get to include humanitarian workers or volunteers themselves who had participated, and that would have been a great addition, but we that wasn't in, we weren't able to do that. But I think working with the experts who have provided it was extremely helpful to kind of get their opinion and to see, their lived experience. And that was really helpful.
Yeah, there's a follow-on question to that as well, which is, the audience for the research that you've done is business, business leaders. Those are the people that are going to be really interested in looking at this evidence that you're producing. And those people, I'm generalizing massively, but I imagine they don't read a lot of academic papers. They might read other types of evidence. So how did you tailor your outputs, or how are you going to tailor your outputs to make sure that they're actually going to be relevant and useful for those people? Ishtar, do you want to come in on that?
Sure. I think this gets back to some additional information for the first question as well. What we found was really important was to start with a concept of the intervention that we were interested in, and to iteratively work on that with Beck and with Ria, who are, as Ivan said, really make themselves very available, because it's not sometimes very clear what your scope is. And so by refining the scope of what the review focuses on and thinking about creative ways to get at data and evidence, really prepares you to think with the end in mind. Who are the stakeholders that I want this message to really impact? And the outputs or deliverables are not, for this commission, for the one that we participated in, are not strictly academic outputs. We need to also produce an infographic. We need to produce a video that presents the findings in a very brief and clearly understandable way to a lay audience. And then to have had the opportunity to present at, for example, the World Economic Forum, that virtual type of platform, was also interesting, because for us, from a low and middle income country context, having that visibility also gives us more leverage when we want to liaise with stakeholders in our local context and to think about the type of output that they want.
It sounds like, researchers are always thinking about how they disseminate in this new world, this new online world. And it's a big challenge for researchers, I think. It sounds like you're going to learn something if you do this kind of work along the way about dissemination. You're going to improve your own skills, I think, as part of it. So that's something for people to think about, I guess, when they're applying. There's one final question for you guys, and that's really thinking back about how you worked with the Wellcome team on this commission. Is there anything you know now that you wish you'd known at the beginning, or anything that you think you would have done differently now, looking back? Who would like to come in on that?
I can just say very quickly, we would have talked with Ria and Beck much sooner to think about the scope, because we felt a bit intimidated by this being a commission and how do we liaise with the Wellcome Trust. But Beck and Ria are very, very personable and really help you to think about a focus. So we have the area, what is the focus, and how can this really be meaningful and impactful? So no question is stupid. I think that's really important to emphasize, to ask questions, because what is relevant to you in your context, particularly if you are from a LMIC and you're thinking about workplace issues or issues where people work, which are often in the informal sector, and thinking about how to work with literature and evidence around that. There are very creative ways that are rigorous and yet are still faithful to the context that you're trying to represent. So I think ask questions, ask as many questions as you need to, and work with them.
That's really helpful, Ishtar. Thank you. Any final thoughts from, yeah, Will, do you want to come in?
Yeah, I can come in. I don't want to go too off topic, but I mean, just to echo what people are saying, they were very easy to work with. And I think Ivan already picked on this, but especially from Rand's perspective, where we work with a lot of government stakeholders and policy organizations, sometimes they're very prescriptive on what we need to do. They've asked very, very specific things, whereas Wellcome were very, we want you to do the research, here's the brief, but the way you go about it, we changed some things along the way. They gave us license to do that, which was really, really good and unique, I think. And then finally, going back to your earlier question about kind of, yeah, having an audience of business leaders and people who maybe don't read academic literature as such. That was a fantastic opportunity because we produced a short, direct report, which is maybe a way of writing that we weren't used to. So I think we definitely learned something very different doing this. But whilst we also wrote a separate annex with more detailed methods, etc. So it was really a very well-rounded, balanced. You could target whoever you want with it. So yeah, it was a good opportunity all round.
Great. Thank you, everyone, for joining us, for giving your talks and those really useful comments. You're getting lots of love in the chat from people saying thank you very much for your time and for your comments. So do stick around for the rest of the webinar, but now we need to move on. And so it's time now for our 15-minute panel session about involving people with lived experience in mental health research. And our panel are Grace Gutera, Niharika Magu, I hope I pronounced that correctly, and Kate Martin, all from Wellcome. Grace and Niharika are both lived experience advisors with the Wellcome team, and Kate is the lived experience and public engagement lead in the mental health team at Wellcome. So feel free to turn your microphones and videos on, guys. Kate, do you want to start off just by telling us a little bit about the team and the work that you've done?
Sure. Hi, everybody. So as Andre said, my name's Kate Martin and I lead on lived experience for Wellcome's mental health programme. And I guess broadly what that means, if I can say this briefly, is it means that my role is working alongside a whole team of lived experience advisors and consultants to inform and shape our day-to-day work and decision making, whether that's helping us shape funding bids or make decisions about who and what gets funded. And really making sure that the kind of we bring in lived experience expertise alongside all the other forms of expertise that are really critical in mental health. So one of the key ways we do that is about making sure that lived experience is also genuinely involved in all the work that we support or all the work that we fund. And that's what we're kind of really keen to talk to you more about today, about how to do that. So shall I just carry on, Andre, then I'll pass on to colleagues?
Yeah, absolutely. Yeah, I've got some questions that we can come to at the end, but yeah, you just fire away.
Great. So what we're going to do is I'm going to start off briefly just by talking about a couple of questions about what we mean by lived experience, what we're asking for you from people in this commission. Then I'm going to pass over to Grace, who has been really closely involved in our previous commissions. And so has spent a lot of time reviewing applications and knows what to look for, so we'll give you some advice. And then lastly, we'll pass over to Niharika to add some further perspectives from her experience, both in workplace mental health initiatives and also from lived experience work at Wellcome and other places as well. So I guess, first of all, it's helpful to think about what do we mean by lived experience in the first place. One of the common conversations we have as a team is the need to be more nuanced and more specific when we're using the phrase lived experience. And the first question, I suppose, is lived experience of what? So for commissions such as these, when you're involving people with lived experiences, we're really looking for people with lived experience of the specific mental health challenges that your commission is researching and exploring. So personal, direct, lived experience of the mental health challenges that you'll be focusing on. But also we need to get more specific. So if you are focusing on specific workplaces, specific sectors, then really it's not just experience of the mental health challenge, it's also a knowledge and an understanding and experience of the sector that your research is focusing on, your commission is focusing on. And in terms of what we're asking for, I think I guess the main piece of advice really is to understand and to see the difference between people bringing lived experience expertise and people whose experiences are sought often through research as participants. So when we talk about lived experience expertise, what we're talking about is people who bring that knowledge, expertise to work as part of the review team, to bring in that knowledge and insight, to work alongside you at all key stages of your review, to really make sure that the perspectives, the knowledge, the kind of contextual, experiential knowledge and expertise of people who have experienced mental health challenges in the workplace, who understand the sector and the issues you're trying to grapple with, work alongside you. And I think that's critical to make the distinction from people who have direct experience and being asked for their stories or their personal experiences in the way that we often do in research as participants. So I think it's really key. We're really looking for people to make that distinction. We're not looking for people to be involved as participants of research. We are looking to people to be collaborators who are co-designing, work alongside your teams at each kind of stage of the review. There are multiple ways you can do that. There are some suggested in the document. We can share some more with you, but the main principle is that they're working alongside you as colleagues to enrich and guide the reviews that you're taking forward. I'm going to pause there and I'm going to pass over to Grace to offer some more thoughts.
Hi everyone, this is Grace Katera. I'm really sorry that my camera is not working. I would have loved for you guys to see my face, but that's not happening. But yeah, what I'm going to talk about is what good looks like in this work and what to avoid. And I think they're very simple because everyone has been emphasizing them. I think good looks like having people with lived experience at the center of the research project, having them be involved from the beginning, from conception to the design, to the implementation, and then later on to the monitoring and perhaps even the dissemination. And I just want to emphasize that we are always learning and we're not expecting this to be perfect. And we know that there are limitations to this across the board. So what we ask is just to make sure that you try, as opposed to like, we expect this to be clear, but we hope that you try to involve them well. And then the other thing is to make sure that that people with lived experiences involvement is not limited to a specific category or just to their stories, because people with lived experience have so much more experience and expertise that we can contribute, because we are not just people with lived experience. We are people in the workplace. We are, employees. We are employers. So we can always bring that wealth of experience as well as our lived experience. We come as a package deal, not as just one area. And the other one to avoid is tokenism. People with lived experience may have experiences that echo across the board, but they're not representative of a whole group. And when you do that, then you also again try to pigeonhole lived experience. So I would really desist from asking people with lived experience to represent a majority or a general group, but rather bring in their own expertise and their lived experience, because that's where they excel. That's their expertise. And then also, I think it's very important that you remember to protect the people with lived experience working with you, because there's always some, there's always some personal and professional bias towards people with lived experience and their experiences in workplace. And I know that personally also, in coming from a law to an LMIC, that my experience professionally might differ from someone in a high income country. So working within that context and understanding, because people with lived experience understand best, their workplaces and understand the stigma that they face there. So sort of working with them to make sure that they're safe and that while they're contributing, that it won't have like long-term repercussions on their ability to work and make money for themselves. Yeah, that would be great. Lastly, I think just making sure that you pay them. we always emphasize this at Wellcome, and I would like to emphasize this. I know that there's a provision there, but yeah, please remember to pay people with lived experience for their contributions. I'll stop there and pass it on to Niharika.
Thank you, Grace, and thank you, Kate. I think I truly echo with all the thoughts that both of you mentioned. You've covered most of the points. What I'm going to share are some of the examples of how previous commissions have involved people with lived experiences. But before that, I think as someone who has been in workplace settings from the age of almost 18 and has spent about 19,000 hours doing that in different startups, companies, institutions, I know that workplaces don't address mental health concerns truly, and there's a huge opportunity to change that. But when we go to businesses, we're often asked for what is the evidence behind it, or what is that thing that would work, because no one knows what would work till now. So I'm glad that you all are here, because you all are going to help us find that evidence and take that to the right people to make change happen. So that's just great. But that cannot happen without involving people with lived experiences, because these are people who have an expertise. They are experts by their experience, and they are like any other colleague, like Kate and Grace also mentioned, they're like any other colleague that you will have in your teams. So there was an active ingredients commission that Wellcome had last time, and that had some really good examples of involving people with lived experience in throughout the process, because it should not just be a check mark at the start of the project and at the end of the project, but something that's followed holistically throughout the process. And I'll share some of those examples, but these are totally the starting points. These are things that we've discovered now, and we are sure that many other ways that you will help us discover. So some of them are that review the study scope and design with these people, refine what kind of research questions you're going to ask with these people, refine the search terms that you're looking at with the help of them. Involve them in co-developing and co-facilitating things, not just like reviewing things, but involve them in the entire process, take their learnings. It'll help make the research settings also comfortable for a lot of other people. Discuss the things that the findings that you're finding with these people, because they might help you translate data into something else, and they might help you look at things that you're not able to infer that well. They'll help you identify future opportunities, future research opportunities from the existing things. And they can also help you share that report, disseminate that report, use their existing networks to take these learnings far and wide. So these were a couple of examples. I truly hope that we're able to involve people with lived experiences throughout these projects and have some really great learnings from it.
Brilliant. Thanks, Grace and Niharika. And just one final thought to say is, as you both touched on, this is learning for all of us. So we are really keen to drive forward the involvement of people with lived experience, find the best ways of doing that. We're certainly not saying as Wellcome we've solved it. We know that we have a really important role in supporting this to happen. So throughout your work with us, we will continue to sort of work alongside you to understand the range of methods and approaches you're using, what works, what doesn't, and to really kind of build a bit of a community to think about how we can advance this practice. So we would be really looking forward to working alongside you all as this progresses.
So I'm just going to ask a couple of follow-on questions. That was brilliant, guys. Thank you. Grace, you mentioned money, which obviously is a really fundamental thing, and weirdly something that a lot of people forget. Obviously, we need to pay people with lived experience who we involve in our projects. Have you got any recommendations or any suggestions for how much people should be paid for their time?
You know, that's a really good question, Andre. I will cheat here and sort of push this question to Kate. And, Kate, please help me here.
Sure. Yeah, I think it's a really important question. And I think, so my first point, I'm not trying to cheat on this question and get away from answering it, is we get stuck in these loops of how much should we pay somebody with lived experience. And it's like, well, but let's have a look at what knowledge, skills, experience they're bringing, like we do in any other form of employment. I'm seeing some really interesting comments and chats in the chat, actually, which have kind of really kind of made me think more about this. Is, you know, people with lived experience are not just somebody who had experience of a mental health challenge, as Grace and Niharika have said. They are people who might be senior members of the workforce, who might be skilled and experienced in all sorts of other aspects of the work that we're doing or the workforce that they're in. So we need to pay an appropriate amount to their level of skills and experience. So I think it's really hard to say one amount. I think the basic fundamental principle is they should be paid. I think it's impossible to say how much people with lived experience should be paid, because they will all bring different levels of experience, knowledge, skills. They'll be expected to take on different levels of responsibility in the reviews. So I would say, look at what you're paying other people in the research team and make it equitable as far as possible, is probably the best answer I can give. But Niharika or Grace, please do chip in.
Yeah, and I think also just to add on, as you go on to different projects, or as their expertise also kind of grows over the years, there is a possibility of seeing that is there a seniority level in this part of thing as well as any other job. So and that could kind of work alongside the pay scale.
Yeah, and one last comment I forgot to mention, which someone's pointed out in the chat really helpfully, is, you know, by seeing lived experience as a form of expertise, of course, that expertise can sit alongside other forms of expertise. So of course, there'll be many researchers who work in this field, or practitioners who also bring lived experience. So the lived experience transcends multiple roles. We're not just talking about a separate group of people here. We're talking about many of us, myself and many of my colleagues included, bring lived experience, as well as a whole set of other kind of research or practice skills. So I'm sure there'll be many people in your teams who have who bring other knowledge and perspectives along as well.
Brilliant. Thanks, guys. We've got half an hour left, so we're going to move on now to our final session. And this is the Q&A, talking about the new commission on workplace mental health. So if you're planning on applying for funding and carrying out some research in this next round, then now's the time to ask some questions. We've already got hundreds of questions, and we've tried to compile them a little bit. And so we're going to start off with some of those, but do carry on asking them in the chat, because anything that goes unanswered today, we will address after the webinar. So our panel for this session includes Beck and Kate and Grace, who you've already met, plus two people who I haven't yet introduced. That's Catherine Sebastian, evidence lead for the mental health team at Wellcome, and Ria Newman, who's the policy and advocacy advisor at Wellcome, who many people have already said very lovely things about. So turn your cameras on, guys, and let's get you in the Q&A. So Wellcome, I wanted to start off with a couple of just general definitions, because a lot of the questions that have been in the chat so far have said, you know, what do we mean by mental health? Are we talking about mental well-being? You know, where's the boundary there? And also a definition of workplace seems quite important. So Beck, do you want to start off by just giving us a bit of a sense of where the boundaries are there?
I can. I'm going to pass the definition of mental health over to Kat, because as our evidence lead, I think she'll be much more articulate, but I'll definitely come back on how we're defining workplace.
Okay, over to you, Kat.
Thanks, Beck. So I think that we are mainly interested in mental health symptoms that impair functioning. So I think for us, that's the main criteria. So we're looking at mental health problems that go over and above the sort of typical ups and downs of daily life, and looking at those that cause more major distress or impairment of functioning in everyday life. And just to reiterate what Beck said at the beginning, for the 2020 Commission, we had focused on anxiety and depression in young people. For this commission, we're interested in mental health symptoms more broadly. So I think I saw someone in the comments had mentioned PTSD symptoms. So that would be in scope, psychosis that would be in scope, and many other mental health problems besides. So yes, broader scope this time in terms of the mental health problems covered, but still very much focused on problems that cause impairments in functioning in everyday life.
Okay, thank you. So let's just stick with mental health for a second, and we'll come back to workplace definitions, because Beck, I wanted to ask you, just to follow on from that, you focused on younger workers and anxiety and depression, as Kat says, but this commission has got a broader scope. So you're thinking about workers of all ages, all sorts of other mental health problems. Can you tell us a bit about why you're broadening it out?
Sure. So the biggest reason is that it's in line with where Wellcome is going in mental health. So when we started working the priority area in January last year, our remit was very much younger people, anxiety and depression. As mental health becomes this much bigger part of what Wellcome is doing, we want to make sure that that is reflected in the scope of this commission this time, which is why we've lifted the age focus, because that is what's going to be happening across our work on mental health more broadly, and also why we've removed the focus on anxiety and depression to consider all mental health problems, because that is going to be the scope of Wellcome going forward as well. It isn't just going to be that focus on anxiety and depression. I did notice, if I can follow on, there was a question on the chat saying, does that mean you're not interested in anxiety and depression? And that's not the case. If as you are doing your review of the existing evidence and you see something that's particularly solid in terms of the evidence, or you think it's something that we need to be aware of in particular relation to anxiety and depression, then please do include that as you're writing your report, because it's not that we're not interested, it's just that we are allowing a broader focus.
Great, that's really clear, thank you. And so what about workplace? How are we defining that?
So as you will have heard from our fantastic researchers, lots of the workplaces were traditional office-based workplaces, with the exception of the fantastic work that Ishtar did thinking about the kind of hospitality sector. We are really interested in a broad definition of workplaces. And I think if you look at the RFP, when we talk about workplaces and workforce, you know, we're interested in specific industries, particular populations in the workforce, those working in the informal economy, low paid workers, those with insecure contracts. So we are really interested in this kind of broad definition of workplaces. It was just that in the last commission, there was a slight skew towards kind of an office-based scenario. But if people have ideas for different workplaces that can be considered, we're really, really interested in those.
Great. Okay, Ria, I've got a question for you now. Businesses are sometimes criticised for putting in place tokenistic workplace mental health approaches. This has certainly come up in the chat already in the webinar, and failing to address some of the key structural issues that may impact on employees' mental health. So we're thinking about things like excessive workload or lack of management support. Are you interested in research proposals looking at these wider structural or cultural factors?
Thanks, Andre. So yes, absolutely. So we are interested in any approach that the researchers hypothesize may have an impact on preventing or addressing mental health problems in the workplace. And that can span things, as you'll see from our last commission, like mindfulness, right up to something like employee autonomy, which is a really fundamental part of something that people may or may not have in their role. So I think we're interested in approaches across a very, very broad spectrum. I think the other thing to say is that when people are researching a particular approach, we are also really interested in what the evidence says about how contextual factors influence how that works in practice. So if there are contextual factors such as things around culture or around workload or around management support that are impacting on whether an intervention works or not, or whether it works for different populations, we'd be really, really interested for that to be brought out, as well as being open to considering the evidence behind some of those approaches, such as something that tries to reduce workload or something that's aimed at manager support, etc.
Great, thank you. So what you funded so far, and this is true of the Active Ingredients Commission as well, has been reviews. You've asked people to review the existing evidence. And what we've seen already from some of the talks is that those reviews have highlighted big gaps, big limitations. Maybe this is one for you to answer, Beck. Are you planning to commission any primary research on workplace mental health that, you know, identifies and fills some of those gaps?
Yes, so I think maybe it's worth me starting by saying like why we're running this commission again. So we funded 10 groups in the first instance, and you will have heard from them that the evidence base we know is quite patchy. I think there is still a lot to learn about just how patchy that evidence base is across lots of other approaches, which is why we're running this commission again. Because one of the things we want to do is incentivize people to address these evidence gaps. So the more evidence we have about the size of the gaps is actually helpful for us from a kind of advocacy point of view. Secondly, is just it informs our understanding of where the gaps are. So to your point about primary research, both the former commission and this future commission are going to kind of help us to understand where we need to put our efforts when it comes to primary research. So that is going to be something that we're going to be doing at Wellcome. I would hope that we might be able to share more information about what that might look like towards the end of this year.
Great. And Kat, a follow-on question to that for you. Some of the work that we've seen already today isn't kind of systematic reviews as such. There's kind of all sorts of different types of reviews of grey literature, literature reviews. Are you looking to fund systematic reviews with this, or are you looking for a broader publication type?
Definitely a broader range. So systematic reviews certainly have their place, and we've funded several of those, but we want people to come to us with any methodology that they think is best placed to address the workplace mental health solution that they're interested in. So, you know, for example, a systematic review may not be appropriate if it's an area where there's not so much research, or where the researchers want to focus in particularly on this question of context or on cultural sensitivities. So I think there are a range of approaches and methodologies that we would accept as long as they're well justified and well specified in the application form. I think important to say we're not interested in forming a sort of hierarchy of methodologies where, you know, we would say, oh, systematic reviews are better for this commission than other forms of review. So do come to us with all your ideas, because we appreciate that systematic review may not be the best review methodology for all topics.
And can we have some clarity as well about the type of interventions that you're interested in? Are you looking at prevention? Are you looking at tertiary interventions? Are you looking at people focusing on particular populations within the workplace? What's the remit in that regard?
Ria, do you want to answer this one?
Yeah, I'm happy to take that, Kat. So we are interested in things that may have an impact on preventing, also that may have an impact on supporting those who are currently struggling with their mental health in the workplace, or things that help people who may have struggled with their mental health and then support them with their ongoing management coming back into the workplace. In the expression of interest form, there is an option for researchers to indicate whether they are wanting to focus on a particular time period, but we're quite broad in terms of what we're interested in. Ultimately, it's anything that might be helping to prevent or address mental health problems in the workplace. And again, as we said with the type of intervention, I think the key thing for us is that we want to look at one intervention for each research proposal. So we want people to focus on one approach that they hypothesize could be making a difference. But as to what that approach is, we're really open to different proposals about things that people hypothesize are making a difference. Hopefully there needs to be some evidence out there, because we are looking at the existing evidence around these approaches, but anything that people think might be making a difference in the workplace context would be within scope of the Commission.
That's great, thank you. We've had a few messages in the chat as well from people saying, so how do I participate? Is there a document? Is there a link? Don't worry, if you're in the webinar, we will email you afterwards. If you signed up to Eventbrite, we'll send you all the links to the expressions of interest page and all the reports that you need to look at. And if you're watching on YouTube, just go to Workplace Mental Health on Twitter and using that hashtag, and we'll be sharing the links to that later on today, so you won't miss out on any of that stuff. I've got a question here for you, Kat, which is thinking more about the type of person who is applying for the grant. Is it mandatory to have somebody on the team who is a kind of PhD in mental health science? What kind of makeup are you expecting in the research teams? I guess you might have charities applying, you might have businesses applying, you may have universities. What are you looking for in that sense?
I think that's one of the strengths of the Workplace Commission in particular, is that we've had applications not just from academic institutions, but as you say, from charities and workplaces, and we're very keen to support that. And we recognise that not everyone in those organisations would necessarily have a PhD in mental health science. So I think what we say is one person in the team should either have a PhD in mental health science or can demonstrate equivalence, and we'll try to be flexible on that. I think what we would say is the main thing that we're looking for is an ability to demonstrate experience in a particular review methodology. So for example, if you are proposing a systematic review, for example, we would ask that one person in the team can demonstrate that they have experience in that methodology. And that experience could have been gained in an academic setting, or it could have been gained in a workplace setting. So that's the main thing. The reason we say that is because the output from the Commission, the primary output, is going to be an insight analysis using that particular methodology. So that's the main reason for that criterion, but we will try and be flexible to diversify the pool of those included in the Commission.
Great. And I suppose to follow on from that, in terms of the team that you're looking for applying? Ria, maybe this is one for you. Is there a maximum size of team in the research applications? And can you have co-leads and these sorts of projects?
Thanks, Andre. So I'll take the co-leads one first. So no, for each application, we are looking to have a single lead, and the contract will be agreed with that lead representing the whole project team. So we are not accepting co-leads for this request for proposals. In terms of team numbers, we haven't set a limit. In the expression of interest, you'll be asked to give details of up to 3 team members, but we're not setting an upper limit, although we would encourage people to think about kind of what's necessary and kind of the people that you need. But as Kat was saying, we are keen to be having partnerships. So if there are people you can bring into the team from different organisations that might be relevant, we are very open to that. And one thing, just picking up on some questions we had in advance and some of the questions we've had about the request for proposals, we are very open to people with lived experience who are going to be involved throughout the project being named as collaborators on the proposals, so they can also be named as team members.
And can that lead applicant be from a charity or from a business, or do they have to be a university employed person?
No, they could absolutely, they could be from the sector. We will consider, as Kat was saying, we'll consider the expertise of the team as a whole when we're reviewing applications. So they could be from a charity, they could be from a business. It's whoever within the project team that I think feels most appropriate to put themselves as lead. And the key thing from us is that that lead is able to accept the contract from Wellcome.
And I guess one of the things you're doing here is you're kind of bringing together organisations from within this sector who may not necessarily have existing relationships. It might be that businesses don't have existing relationships with universities, or charities don't. In what ways are you thinking about industry partners developing relationships with academic departments? Beck, is that one for you to answer?
That's a really nice question. So I'm so sorry for the quality of my camera. The title of the report where we summarise the research that we commissioned last time is called Putting Science to Work, and it is intentionally called that because we want to position science and research as a resource that businesses can use to better understand the impact that the approaches to mental health that they are currently deploying are having. And so we're really keen to kind of bridge this gap that exists in some places between researchers and academics and businesses, which is why we're really lucky that Wellcome has an existing relationship with the World Economic Forum that's been really, really helpful to us. And I know that some of the speakers spoke to this in their presentations, and that we gave them the opportunity to present their kind of early findings before we published them to large numbers of business leaders, so that they could have a kind of open conversation around what did the research look like, what have you found, what might this mean for businesses, and why, as Ishtar was saying, some of the deliverables are slightly different to other commissions. So we are looking for like infographics and recommendations and videos and sorts of engaging content that we can take to industry to kind of help forge these relationships between those two sectors. So it's a really important part of this work.
And is there something specific that you're looking for from industry to contribute to this commission?
So I think at this stage where we're asking people to review the existing evidence, it's thinking about how you might incorporate this evidence into how you think about the approaches that you're using at the moment. Because I think from the conversations we've had with businesses, this isn't a huge part of how they think about which approaches they might use. And that's largely because there isn't a huge amount of evidence for them to look at, but it's really being willing to think about, okay, if we were trying to understand what might be the most effective approach that we could deploy, how would we make that decision? And it's making that evidence base more accessible.
It feels like there's something with the active ingredients work, which is true here as well, in that you're kind of building a community and you're bringing together some of these disparate groups, and that you've got a kind of facilitatory role there, and you're kind of recognizing that at Wellcome. I wonder how that's going to be different in this space to the youth mental health space, what the challenges are going to be to kind of facilitate those links.
That's a really good question. So I think one of the things we've been thinking about a lot, and this particularly looks to the kind of primary research that's on the horizon, that we hope will involve industry in a much more direct way in terms of understanding the impact that the approaches that they're using are having, is thinking about the issue of data. So one of the challenges we keep thinking about internally is what researchers would need to collect in order to understand the impact that a particular approach is having, and what that might present in terms of challenges for businesses, in terms of how that data is collected and how comfortable employees feel about their employers holding that sort of data. So I think that's a challenge that we hear from both sides of this conversation. And I think something where it might be possible for Wellcome to kind of, as you say, bring those two sectors together and sort of help them figure it out.
Great, thank you. Kate, I've got a question for you, and I think it's kind of a question of clarification, or really a question for you to kind of reinforce what you've already said. Questions about primary research and lived experience. So you're saying we don't want any primary research applications, but you're talking about involving people with lived experience. You know, how's that possible? So just reiterate for us what we mean.
Sure, and I think really great for the really great question, and I think this is where it highlights how clunky I think the language is still evolving in this space, and it can be hard to, I guess, distinguish the differences. So, primary research we would see as using whatever methodology, interviews, surveys, whatever, collecting the experiences, views, opinions of people who have experience, and using that to analyse and inform a piece of work, so a piece of research. So. And that's not what we're looking for. We are not looking for primary research that interviews or collects data from people who have experience of mental health challenges. When we talk about lived experience for this proposal and others, we are looking for people who, yes, have a direct experience of having lived or living with mental health challenge, but they are not offering their personal experiences to inform the project. They're offering their knowledge and expertise to co-design each stage with you, just as you will have people with expertise about systematic reviews, expertise of the sector, for example, expertise of implementing strategies in the workplace. We're asking that a kind of an additional form of expertise brought in is the lived experience perspective. So just to kind of clarify, they are not there to share their personal stories. They're there to offer kind of advice, knowledge and expertise based on knowledge of the wider issues, I suppose, that people with lived experiences in the workplace might face. So issues like stigma or access to interventions, knowledge that I guess couldn't be gained elsewhere, and to bring that alongside, to be a core paid member or members of the research team to work alongside the review team in all the key stages of that review.
Brilliant, thank you. So last question for everyone, I think, is really about, you know, now we're at the end of a pandemic, hopefully, coming out of that, and how do you see workplace mental health evolving right now? Is it going to be very different to how it was a year or two ago? And how's that going to impact on this commission?
That's a really good question. So I think, as I said in my slides at the beginning, one of the things that we have heard largely anecdotally so far is that this issue seems to be more of a priority for business leaders than it was prior to the pandemic. So they are being forced to consider their employees' mental health, perhaps in a way that they weren't before, and that we're seeing a rise in the number of kind of chief medical officers and chief health officers and chief wellbeing officers that are being employed by these big organizations. I hope that means this commission is being run at a particularly kind of right moment that we can exploit to get this issue of evidence as part of this bigger conversation around workplace mental health. Because I think as the pressure on businesses to take it seriously and perhaps fund it to a higher extent than they have done before, it feels like we need to make sure that one of the things they're considering is how evidence the approaches are that they are using. So I'm hoping that just as we had brilliant conversations with businesses through WEF when we released the results from the first commission, we'll be able to do something similar, and perhaps with an even larger number of stakeholders this second time around.
If I can go next, I would like to point out. I would like to point out, Andre, that for a lot of places in the world, the pandemic is not even close to being over. for this phase is just another new nightmare that has just started. So I think that one of the things that for me stands out is that we've always spoken about a new normal. But the thing is that it's not a new normal. This is our existence now. There is no pre-pandemic times. There's no we can't go back to the past. And so employers now have to contend with that, have to contend with, not even employers only, but employers and employees have to contend with working even when the world is falling apart right next to you. So not to think, when you don't think about mental health and when you don't think about lived experience at work, you're making a big mistake for many reasons. But yeah, this is why this commission is timely and this work is necessary.
Thank you, Grace, for that important reminder. Well said. Anybody else want to come in?
Yeah. Oh, you go ahead, Kate.
After you.
Thanks. I was just going to say, I'd be interested to see any emerging data on how workforces think that their industries have handled the mental health aspects. And I think that will be really useful evidence in feeding into our understanding of what works in different contexts. So I think from a research perspective, it is a potentially important time that we can learn a lot from, assuming the data is available. I think one of the key issues is, I think has been raised in the comments, whether interventions are perceived as being tokenistic or whether employers are able to really sort of translate words into actions. I'd be interested to see what factors reflect success in that area. I also think, bearing in mind what Grace has said about in many places the pandemic not even being close to being over, in some settings, such as the UK, where we're hopefully tentatively looking forward to a sort of emerging back into the workplace as opposed to remote working. It'll be interesting to see how models of flexibility and hybrid models play out and how that's going to impact on mental health, because I think potentially that's a really important opportunity, but there are so many pressures on business and workplaces to carry on with work and get back to normal, that there's of course the worry that we might slip back into the old non-flexible ways.
Thanks, Kat. Kate, final word to you before we close.
Great. I guess what would the future look like for me? It would be where workplaces have a whole range of well-evidenced interventions and approaches to choose from, so that then we can kind of support greater kind of personalisation and choice for employees to know that there are different approaches on offer. That I think we need to understand what works for who before we can really start to work then with employees in different contexts to really find the best approaches for them in their own specific context and situations. And that critically, this is something that comes out really strongly from all our work engaging with young people and young adults and our lived experience advisors, is that it's not just understanding what works, it's understanding what doesn't work and when things are just either not working or actively unhelpful. And that's something I don't think we talk about enough. So I think I'd see a future we have a much better understanding of what works for who and what doesn't, to really enable better choice and a much better support for people in all sorts of different workplaces.
It's a good point. Stop doing stuff that's harmful and doesn't work at all. Yeah, absolutely. So we're out of time. Just a couple of very important things to say before we finish though. I hope that Ria can post in the chat the link to the Wellcome website that everyone is going to have to go to over the next couple of weeks if they want to apply for some funding. We've covered loads of questions today, but if any have gone unanswered, we'll try and answer those on the website in the FAQ section. We'll try and bring that all together. We'll share the recording of this webinar. And yeah, I mean, just to say thanks really to all of our speakers who've all spoken so well today, and to all of you guys who've attended. Thanks very much for joining us, whether that's here in Zoom or on YouTube or on Twitter. And finally, just to remind you, the deadline for expressions of interest is 12 o'clock midday on Monday, the 28th of June. So that's quite soon. That's the expressions of interest deadline. You need to do that if you want to be considered. So get on that as soon as possible. And yeah, we're going to close the webinar now. So thanks very much for everybody, and we'll see you again sometime soon.